Hi, I'm Dr. Tom Field, and I'm going to be talking to you about stress and trauma. Now that we've learned about the nervous system, we can now turn our attention to the sympathetic branch of the autonomic nervous system and understand what happens when a person feels stressed, some of the adaptive nature of stress, as well as some of the maladaptive parts of stress, and that cause things like adjustment problems and also traumatic stress. We're going to begin with a reflection question. What do you notice in your own body when you experience high levels of stress? Just think about that for a moment. And then what have been the impacts to your physical and mental health? Okay. I'm sure all of us can relate that stress has an impact on our physiological functioning, right? That when we feel stressed, we feel tightness in the chest or inhibited gut functioning, all those types of things. And we also have experienced things like mental health issues or maybe even physical pain, physical concerns when we've been stressed. The reason for that is that the stress response system does have important functions to our own mental health and is a sign, it's like a signaling system to tell us that there's something in our environment that we need to do something about. And when that signaling continues on for long periods of time, it becomes problematic. Before we get started, before we dive into the problematic aspects of stress, I want to emphasize that we are incredible organisms. Our brains and bodies continually adapt to the environment. In many ways, cortisol and adrenaline are all about that adaptation, right? Change is therefore always possible through neuroplasticity. And the brain and body work in concert with one another, okay? Change always possible. It's important to emphasize this because we can go into this feeling like, well, we're doomed, right? This is just the nature of things. But the truth is, even things like traumatic stress can be reversed to a large extent, right? Because of neuroplasticity. Okay, let's talk about the adaptive nature of stress. So not all stress is bad. In fact, there's a concept called eustress, which is positive stress. I want you to imagine a spectrum, like a bell curve you see in the picture there. Most of us experience about an average amount of stress during the day. A too low amount of stress or too high amount of stress is problematic. Okay, let's talk about why high and low stress is problematic. Well, low stress would mean, low motivation. It would mean attentional problems, concentration problems, because the stress response system is important to things like alertness, concentration, attention, and is also important to motivating us, preparing us for action. Okay, so imagine you have, for example, a test coming up in a course, and you have very low amounts of stress around that. You may not study, right? You may not have the energy to study. So that wouldn't be good. But too high amounts are not good either. If, for example, with that same test, you feel overly stressed, you may not study because you're almost frozen, right? You're in too high of a stress state. And so high and low stress, the extremes aren't good for us. We want about a middle ground, a balanced amount of stress, which motivates us, gives us energy to do the tasks ahead of us, but does not overwhelm us. Okay, this is called optimal performance when this occurs. Let's talk about cortisol, what it is, what it's all about. It's a hormone associated with the mobilization of energy resources, especially in response to stresses in the environment. It increases blood sugar, it enhances the metabolism of carbohydrates, fats, and proteins, and suppresses the immune system, right? It prepares you for action, moves energy in the direction that's needed so that you have the resources to accomplish the tasks ahead of you. Okay. An example of this would be responding to threats in your environment. Now, once you get activated, that lasts for a period of time, and then eventually the threat passes, right? And what happens is, as I mentioned before, the adrenal glands send a message to the hypothalamus to discontinue the production of cortisol via downregulation. Okay? And the adrenal glands going all the way up to pituitary gland to hypothalamus, that whole signaling pathway. This re-regulation or return to homeostasis is called allostasis. Okay, so in other words, we have activation and also re-regulation that occurs throughout the day, and that is very normal part of functioning. Okay. For some people, their ability to regulate that stress is difficult. And there are reasons for that we'll explore in a minute. But it is possible that some people feel overwhelmed by the stresses of their life. And when that occurs, they can experience some degree of dysfunction. Okay. And so an adjustment disorder diagnosis, which is the first clinical diagnosis we've actually explored in this course, is classified as emotional and behavioral symptoms in response to an identifiable stressor occurring within the past 3 months. There has to be an identifiable stressor, ideally, though I'll add here that this is the most common diagnosis used in outpatient settings. And so often, the reason for that is, often it is considered like the most mild mental health diagnosis. And so for a client who comes in and they don't really have anxiety or depression or other issues, they may be diagnosed with adjustment disorder for insurance purposes. But ideally, you'd only be making this diagnosis if there was an identifiable stressor. Okay. They have to be experiencing distress or impairment, and they do not meet the criteria for another mental disorder. So if they do meet the criteria for anxiety or depression, they would not be coded with adjustment disorder. Okay. It's not normal bereavement. A normal bereavement is a typical process, right? If a person goes through grief, that is not necessarily a marker of a mental health diagnosis. Things like, for example, missing the deceased, profound sadness are very typical for grief. Once consequences are terminated, symptoms have to cease within 6 months. So what do we mean by consequences are terminated? So imagine that, for example, a person goes through divorce and their divorce is finalized 6 months ago. By the 6 months post finalization of divorce, you would expect symptoms to cease. Here are the specifiers. With depressed mood, with anxiety, with mixed anxiety and depressed mood, with disturbance of conduct. Conduct here meaning things like disruptive behavior. It could be vandalism, it could be stealing, etc. Mixed disturbance of emotions and conduct, and then unspecified. By the way, with that 6-month criteria, you're wondering, well, why do symptoms have to resolve within 6 months? The reason for that is it's meant to be more of a short-term issue, rather than a perpetual chronic issue. However, there are times where that criteria, particularly around time, doesn't quite work for a client. And in that case, you would diagnose them with other specified trauma and related disorder. Okay, trauma and stressor related. So, for example, they could have an adjustment disorder with delayed onset of symptoms that occur more than 3 months after the stressor, or an adjustment disorder with prolonged duration, more than 6 months after consequences end, as I just mentioned. In those cases, you would diagnose F43-8 rather than the adjustment disorder diagnosis. I'll note here that there are other cultural syndromes that look like adjustment responses that you could also code as F43-8, such as ataque de nervios. And last but not least, persistent complex bereavement disorder. This is the only place where this occurs in the DSM-5. It's under conditions under further study more formally, but it snuck into this other specified category. What is persistent complex bereavement disorder? It's more fully explained in the conditions for further study, but basically this would be symptoms of bereavement that are more severe, more persisting than one would expect, more complex than one would expect through a normal bereavement process. So what are adjustment stressors, you might wonder? What are the kinds of things that a person might be experiencing that create undue stress? And there's a lot of different examples. Here are some of them. Acculturative stress, moving to a new country, for example, or moving to an entirely different area. Maybe the person grew up in the rural area, moves to an urban area. Something that they're adjusting to. I think when there are language changes, this is particularly notable. Bullying, which can, of course, persist throughout childhood, but may be a discrete incident. Discrimination, this could include things like racism, homophobia, misogyny, transphobia, those types of things. Divorce, breaking up with someone tends to be very stressful. I think what's the phrase? The 3 most stressful events in life are marriage, divorce, and moving. Marginalization, the sense that you're being ostracized, being left outside of important groups. This may occur in communities, it may occur in schools. Poverty, living in poverty is very stressful. Toxic work environment, maybe the people around you at work are, just difficult to get along with, and it creates a lot of stress. Especially, I will add here, I've had a number of clients whose boss was very toxic, and that creates a lot of stress. And then violence, exposure to violence. In addition to that, there are other stressors that a person may have experienced during childhood that impact them ongoing. Now, this isn't captured great as adjustment disorder, and it's not traumatic stress. There's an in-between, and some have proposed that this should be captured as something like developmental trauma disorder or something like that. Professor Vanderkolk believes that. But at least we should talk about this. So you're probably very familiar with the Felitti and colleagues' adverse childhood experiences studies that were conducted, I believe, by Kaiser Permanente in the late 90s. And they identified through large data sets situation stressors that seem to exacerbate a person's likelihood or increase their likelihood of having pretty profound physical problems, emotional problems in adulthood. Psychological abuse, physical abuse, sexual abuse, substance use by a household member, could be a caregiver, could be another member of the household, depression or suicide attempt by a household member, violence towards mother or stepmother, and then imprisonment of household member. And of course, what they found was that 4 or more of those stressors greatly increased, doubled, or even tripled the risk for a number of problems that included alcohol and drug addiction, cancer, cardiovascular disease, depression, obesity, sexual promiscuity, which was defined as 50 or more sexual partners, sexually transmitted infections, and suicide attempts. Okay, so you could maybe argue that these things are, related to the stressor and a kind of an adjustment response. They're not captured as PTSD. So diagnostically, if you had a client who experienced pretty profound issues in childhood and they experience stresses moving forward, you're probably still going to be capturing it as either an adjustment disorder or one of these other issues, such as alcohol, drug addiction, or depression. Just know that it comes from a place, right? And you may need to work on helping them to understand what happened to them in childhood. It's worth mentioning too the chronic stress pathway of what happens when your stress response system gets dysregulated. This is, again, distinct from traumatic stress, and so it's worth noting here. Let's say a person experiences a chronic stressor. Let's say we'll use bullying, okay? Over time, they experience a greater amount of stress, okay? And what happens is there's a methylation of genes, a suppression associated with HPA axis regulation. Do you remember we talked about that a little bit? That basically what happens is during the methylation process, that, for example, the turning off of the cortisol tap, if you will, that is impaired. And so what happens is cortisol continues to be secreted at a relatively high amount, and the person eventually, at chronically high levels of cortisol, causes these downstream effects of cell overactivation and degradation. The reason for that is neurons, for example, don't love cortisol. The neurons also don't love chronic inflammation and cytokines. It creates neural death, right? Overstimulates them. You also see a reduction in brain-derived neurotrophic factor and glutamate, which remember is associated with the birth of new neurons and synapses to replace what is being destroyed. And you see immunosuppression, increased likelihood of getting infected, of gaining physical illnesses. Again, over time downstream, if that continues for long enough, you see long-term depression, and volumetric decline or reduction in CNS brain structures. Things like hippocampal volume will reduce. Okay, and the reason for that is, again, you're destroying neurons and you're not replacing them. So you're going to see volumetric reduction. This eventually leads to less CNS control over the HPA axis, and it's a condition known as hypercortisolism. Okay, in other words, the HPA axis just becomes even more dysregulated, out of control, and cortisol continues to flow freely. And eventually you see mental health symptoms and physical health symptoms emerge from this. This helps us understand why is it that you're at increased risk of those problems that you saw, whether you have when you have adverse childhood experiences occur. Okay, those are chronic stressors, and it causes these problems to occur later on down the line. So, what is your role here as a counselor? Well, obviously, to assess for early childhood um, kinds of chronic stressors and try to intervene, right? Try to do your best to address them through advocacy, through family work, through things like consulting with the schools to reduce bullying in this example. Okay, so let's say you have a client who does present with adjustment disorder. What do you do about it? So in terms of prevention, trying to prevent this, you're going to work on coping skills and strategies. Those things are very important. If a person can cope with stress, right, they're less likely to get overwhelmed by it. Identify support systems. We are not our own island, right? That we often regulate interpersonally, and we regulate through talking with other people and finding support from them. And so using our support systems matters during stress. And then advocacy, as I mentioned. If there are things like bullying happening at school or discrimination in a person's environment, we have to address that. Otherwise, they are going to feel stress. Okay. Interventional treatment. We need to be providing briefer, more targeted counseling for adjustment disorder. Remember, it's meant to be a short-term deal. That's last 6 months or less. So psychoanalytic therapy would not work here. Our goal is to reduce sympathetic activation through parasympathetic activation, things like deep breathing techniques. And now there are apps and trackers that can help you to basically monitor the amounts of breaths you're taking throughout the day. In general, if you're taking 6 to 7 breaths a minute throughout the day, you're much more likely to be regulated and to have and to not get overregulated with your sympathetic system. It's amazing. Breathing actually plays quite a role in parasympathetic recovery. And closing goals when you work with clients is to make sure they're prepared for later periods of adjustment when those occur. Okay, we've talked about stress and adjustment. We've also talked about chronic stress. Now we're going to talk about traumatic stress. Quick reflection question for you. Why can one event cause such profound changes to neurophysiological functioning? Imagine you've experienced a traumatic event. How can that one event in your lifetime cause a long-lasting change? Why does that occur? Just think about that for a moment. Part of the reason for it is threat detection, survival response, is a primary motivator for all creatures. And it wires us. It's something that motivates us. It's something that stays with us. Our body does what it does to keep us safe. And that means if it experiences a threat to survival, it will remember that, and it will rewire some of your physiology to make sure you remember that, okay, and are prepared for it in the future. So let's talk about what a traumatic event is per DSM-5. DSM-5 is very specific about what the event can be and what it can't be, okay? It has to be an experience of actual or threatened death, serious injury, or sexual violation, okay? In other words, a person's life or serious well-being is put at risk, okay? Through personal exposure, direct observation, so observing someone else, go through this directly, or learning of an event that occurred to a family member or a friend. It can also be repeated exposure to aversive details of the situation, which, if it's going to be through something like videotape, has to be work-related. So, for example, a security guard watching security footage. It cannot be watching something on TV. This was controversial because of 9/11 and people watching the Twin Towers fall and feeling a sense of trauma from it. And the DSM work group felt like that was not actually a criteria for a traumatic event. Here are some examples of traumatic events: sudden death or of a proximal relationship. For example, family member, could be a significant partner, could be a dear friend, or a pet. Abrupt separation of a proximal relationship. And proximal meaning here, when I say friend, they have to be like a very, very, like your best friend, not just like a person within your circle. Interpersonal violence and sexual assault that includes witnessing, natural or man-made disasters, earthquakes, etc. Serious motor vehicle accidents, serious injury from burns or dog attack, or as an example, major surgery or life-threatening illness, and war or political violence, bombing, fleeing refugee status. Okay, you get a sense here, right? These things are all pretty serious events and would cause a state of shock. So let's look at what post-traumatic stress disorder is in the DSM-5. There are two criteria. We're going to focus on the latter criteria of children aged 6 and above. The other criteria is for children aged 6 and below. So what we're looking for here is the traumatic event, as we've described. There has to be a traumatic event, and there have to be, for at least 1 month duration, the following symptoms. Now, let's just quickly pause and say, if the symptoms that I described are present, but they have lasted for less than 1 month, you are diagnosing instead acute stress disorder, which is basically the same criteria as PTSD. It's just that symptoms last for less than a month. The reason they have that diagnosis is because sometimes, for example, after a natural disaster, let's say Hurricane Katrina being an example, people may experience some initial kind of PTSD-like symptoms, but they resolve by themselves. Okay, so this is just for persisting symptoms. You have a cluster of symptoms. You have actually 4 clusters: distress, avoidance, change in cognition or mood, and arousal or reactivity. Distress is defined as memories, dreams, or dissociative reactions that are distressing, such as flashbacks. People don't like to have flashbacks. They don't like to have memories and dreams associated with the event. It's distressing to them. Intense or prolonged distress and exposure to symbols or resemblances, and physiological reactions that are, again, distressing. An avoidance of memories, thoughts, and feelings about the event and external reminders, not wanting to go there, not wanting to think about it, not wanting to talk about it. Change in cognition or mood, dissociative amnesia of the event, can't remember details of the event or what happened. Negative beliefs about self or the world, distorted cognitions resulting in blaming self or others. Negative emotional state, that is, for example, fear, horror, anger, guilt, or shame is provided as examples of this. Anhedonia, loss of interest in things one used to enjoy. Detachment or estrangement from others. And flat or dulled positive emotions. Okay. They can also experience arousal or reactivity, and this can be marked by emotional outbursts such as irritability and anger. Not everyone who experiences PTSD experiences anger, but it can be quite significant. Reckless or self-destructive behavior, again, not experienced by everyone, but it can be there. Hypervigilance, that's the scanning of the environment, being on edge, right, waiting for the shoe to drop, if you will, a person to be at threat again. Hyperstartle response, that a loud noise, for example, makes a person jump more than would be expected. Problems with concentration and sleep disturbance. So all told, you can see that there are a lot of different ways in which trauma affects people, and you have to meet the criteria for these symptom clusters, if you will, to meet the criteria for PTSD. Okay, so you have to carefully, when you're looking at a client who may have PTSD, you have to carefully ask questions about all of the symptoms they're experiencing to really get a full picture of the extent of the traumatic stress. So we're going to spend a few minutes talking about the neurophysiology of this, what happens in the brain during traumatic stress and after traumatic stress. From a biopsychosocial model, we're going to look at the biological component of it, and then we'll also weave in some of the psychological and social component of it, okay? Let's talk about the function of adrenaline. Adrenaline has a role in increasing blood circulation through dilation of blood vessels, increases heart rate and output, increases respiration and bronchodilation, so oxygenation of the blood, enhance lipolysis or breaking down of adipose tissue and energy fat stores, increased carbohydrate metabolism and reducing digestion, believe it or not, digestion actually takes up quite a lot of energy to break down foods, and preparing muscles for exertion. For example, you often hear of stories of feats of great strength in crisis, such as a parent lifting a child from under a trapped car. Okay. Again, all of these things help a person get ready for action, right? They're not bad things in and of themselves. And what I'll note here, though, is these things are also associated with stress, right? That a person will say, "Oh, I feel stressed because of these things," because their heart rate's increased, right? Or they notice themselves like feeling flushed in the face, etc. Let's talk about the way in which adrenaline works in the system. Okay, so a person detects threat consciously or unconsciously, okay, or pre-consciously. Implicit memories are invoked about the threat in the past if a person has experienced that threat before. Let's say, for example, a person's experienced bullying and they go to school. Well, actually, no, that's not a great example of traumatic stress. Let's use a different example. Let's say a person has experienced um, physical violence at home, okay? And let's say when they are, let's say when they're out and about at work, someone touches their shoulder without them seeing it, from behind. Okay, it may invoke implicit memories of being physically assaulted, physical abuse as a child, without even them being aware of it. And all of a sudden, there's a rapid activation of the amygdala that bypasses the prefrontal cortex. The reason for that is, you have to respond quickly. And the prefrontal cortex, if that is online, it will slow you down, right? Because it'll make you think about, oh, what should I do in this situation? And what are my options? And no, your body needs to respond faster than that. And so it activates the HPA axis, and that sends release of cortisol and adrenaline through the system. And at that point, you are usually have difficulty with thinking through problems, right? You're just meant to respond instinctively. So the person may get completely flustered and leave the situation, or more, maybe even like push the person away from them. All those things are just very instinctual. And eventually there'll be a return to homeostasis, but that happens a while later, once cortisol and adrenaline becomes downregulated. Okay. So that's how the body typically responds. Okay. And the reason that it responds this way is that it's sending energy and resources to keep you alive. Because during physical abuse, you may feel like your actual, well-being is threatened. And so you may have learned to become quite activated during those periods of physical touch, especially anything that feels violent, in order to keep yourself safe. Okay. As I mentioned, you don't have the great ability to think through options to preserve time. Instead, you're responding instinctively and reflexively. And what I'll also note here is that learning occurs rapidly, going back to our earlier question of how could one event change us so profoundly? What happens is that adrenaline actually has quite a large role in learning. And when adrenaline is very high, there is often this very quick kind of change, neurological change that happens. And you'll see all the changes coming up in some subsequent slides around connectivity between prefrontal cortex and limbic area, etc. And what they've actually found through experimental studies, that there needs to be more of them, there needs replication, don't get me wrong, is that when sexual assault survivors in an emergency department are given propranolol, also known as Inderol, which blocks adrenaline, okay, they don't have ongoing symptoms of PTSD to the same extent as they would if they didn't have Inderol propranolol. Okay, the incidence is lower. And so there's a general thought out there that adrenaline, while very helpful at kind of recruiting our energy resources and getting us ready, also can have a role in ongoing post-traumatic stress and this kind of feeling of being kind of alert and on edge all the time. Okay, which leads into, okay, what about after traumatic stress? What's happening? So after traumatic stress, you see some changes happen in the brain. In terms of the amygdala, you see increased adrenaline receptor activity in the amygdala, right? Meaning that at the seat of fear and emotional processing, that basically adrenaline is going to activate that more and more quickly. Okay. So in other words, it just, it doesn't take as much for you to all of a sudden have a fear response. enhances reconsolidation of fear memories, and those are stronger and makes them resistant to extinction. So those persist. In terms of the thalamus and the hippocampus, there is a disruption to memory consolidation in other regards. So while we may remember, for example, fear and fear-based memories, we may have impaired processing of factual information. Memories may be more sensory and physiologically based than detail-oriented. So a person may not be able to recall like all of the facts of what happened, just more of how it felt. In terms of the connection between the dorsolateral prefrontal cortex, dorsal, remember, means towards the top, lateral towards the side, and the anterior cingulate cortex, okay, which means towards the front, you tend to see, again, impairments between these two. That leads to, or not impairments, but basically a less of an ability for the dorsolateral prefrontal cortex to regulate and control the anterior cingulate cortex, okay? And so you see increased anterior cingulate cortex activation and reduced top-down control by the dorsolateral prefrontal cortex. And this leads to less regulation of hyperarousal and less ability to control unwanted thoughts, memories, and images. And that's why you see these, what we call intrusive thoughts and memories, occur more often, that a person has less control over them. And then impaired attribution of time to experiences. For example, a sense that the experience will come to an end. The person may feel like it just perpetuates and goes on forever, and that leads to this sense of being, on high alert, ongoing, perpetuating. You also see impairments, reductions to the again, ability for the medial prefrontal cortex this time to regulate the amygdala, okay? And that leads to the amygdala being a bit out of whack, out of control, with therefore greater fear and threat response, right? And a reduced inhibitory ability. You also see a strengthening of the insular amygdala circuitry, okay? Which creates an exaggerated and perpetual state of physiological arousal, persisting even in the absence of perceived threats. So a person is on high alert even when there isn't a threat in their environment. Okay, so all of this to say, as you can imagine, that this leaves a person with a sense that the memories and emotions they had about the event persist. They are intrusive. They come without a person's ability to regulate them. They also are on high alert a lot of the time, and there's less of an ability to regulate that fear-based responding. That helps us understand why a person may continue to have high levels of cortisol and continue to feel under undue stress and and suffer through their experience post-traumatic stress, right? Because initially that high alert is useful, right? To keep us alert, to make sure we don't get attacked again. But over time, over many years, it becomes quite distressing to a person that they're always getting so activated. So what do we do about this? I'm going to talk us through trauma treatment next. Some clinical tips to begin with. It's important for you to know that trauma is not easy to work with in therapy, though it's therapy and counseling is the primary mode of doing this. 20 to 50% of trauma survivors drop out of therapy. You should also know that unresolved trauma is often a root problem and can lead to a multitude of symptoms or problem behaviors and is a frequent co-occurring condition. So it is something we want to work through eventually in treatment. Now, even when you're conducting an intake and you ask a person about trauma, know that they may not be ready to answer that question authentically yet, genuinely, truthfully. Trauma is not always acknowledged by a client during intake and may even be denied, even if it has occurred, because of shame and avoidance. Shame meaning fears of how you're going to respond and what it'll mean for the relationship, and also avoidance. Acknowledging it occurred might mean having to address it. Okay. In other words, people fear the physiological activation, the intrusive memories that occur when discussing it. Now, in terms of trauma treatments, meta-analyses suggest that trauma treatments are equivalently effective, that there's no one superior treatment, okay? Which is interesting because often the narrative goes that exposure therapy is required, And that's not entirely true, and we'll see why as we go. Here's one example of why it's not required, that no single component is essential. Okay. They have done studies with trauma-focused CBT, and they have experimentally shown that whether or not the trauma narrative is integrated, that's the exposure part, whereby the person has to basically retell the narrative of their trauma, that it only has a marginal impact on outcome. That children and adults who don't have to divulge a trauma narrative, they still make major progress and gains in therapy about equivalent to those who do the trauma narrative. So it's not as if you have to retell the story of your trauma in order to make progress on it. Here are the three major paradigms of trauma treatment: behavioral, cognitive, and neurophysiological. Okay. Behavioral is exposure to fear-based stimuli, building capacity through positive reinforcement. You see an example on the left-hand side of virtual reality, which is often used in the military for that exposure. Then there's the cognitive school, which is trying to help a person make sense of the cognitions they develop, the self-appraisal post-trauma, such as, I'm damaged. And then neurophysiological, which is, can you help a person develop the acceptance of their physiological experiences? Each of these three approaches is important and valid, but their use will vary depending on the client's presentation. So let's begin with I'm going to give you a couple of different presentations to show you how these approaches can be useful. I want you to imagine that you have a client who gets into a motor vehicle accident. Okay. It's a pretty significant accident. And after the accident, they refuse to get in a car at all. They just refuse. And the reason is that you later find the client has associated car with accident, right? That if I get in the car, I'll have another horrible accident. Okay. Or I'll have memories of the accident occur. So what is the typical treatment for that? Just think for a second, write down your thoughts. What steps might you recommend? Probably you suggested something involving some form of exposure-based protocol, right? It involved something like the person first sitting in the car and then, or even imagine sitting in the car and then eventually turning the car on and then eventually driving around the block and then maybe on the highway and then eventually past the place of the accident. That exposure is helpful because it helps the person realize that getting in the car is not equated with accident, okay? That they decouple that association. There are a lot of different approaches that follow this basic behavioral approach of exposure therapy. There is trauma-focused CBT, which uses trauma narratives, as I've mentioned, cognitive processing therapy, systematic desensitization, prolonged exposure therapy. By the way, at the VA, Veterans Affairs, the only two approved treatments of PTSD are cognitive processing therapy and prolonged exposure therapy, both exposure protocols. And then EMDR uses this to a point when looking at exposure to a person's emotional response. I'll note here that that the exposure also is helpful for things like a trauma narrative, not just for getting like actually in a car. Like you can't, for example, with a trauma narrative actually be exposed directly to something like having snakes crawl on your arm or getting in a car. It doesn't quite work the same with a trauma narrative, but the idea is similar, which is maybe there's an event in your life that you have avoided, and by just retelling the event over and over and over again, you reduce the coupling, if you will, the association of the retelling the event equals activation that I can't handle. And so that reduces distress around the memory of the event. Okay, let's use a different example to show you how a different form of treatment could be useful. In this example, I want you to imagine that there's a member of the military, a client you have, who during combat was next to someone or close to someone who they observed was blown up by a roadside bomb. Okay, and they have developed pretty significant trauma subsequent to this. Okay, so what steps might you recommend in this case? Take a moment, jot down your thoughts. Well, what I will say is It depends on the presenting problem. If the presenting problem is that they have intrusive memories and thoughts and they, refuse to go back, for example, into the field of duty, maybe it's more of an exposure protocol you're using. However, what if, I want you to imagine, the person experiences instead cognitive distortions that go something like, it should have been me, right? Or um, if only I had have done something, uh, you know, it would have worked out better. Or even now, like I'm a damaged person because I observed this and I can't get it out of my head. Okay. If that's the case, then if the latter occurs, then you're going to be working at the cognitive level. And the goal here is for a person to develop self-compassion. Compassion focused therapy focuses on this, mindfulness based cognitive therapy, ACT, acceptance and commitment therapy, and rational emotive behavior therapy. The goal here is talking through yourself through basically those thoughts and coming to a place of compassion, right? That was a horrible event and there's nothing really that you could have done about it. And it doesn't mean that you're a different person necessarily. Here are some exercises from Kristen Neff's website about self-compassion. She's the expert in self-compassion that may be helpful to you if you're doing this kind of work with clients. How would you treat a friend? Writing, and the reason that's important is coming from a place of empathy, right? About what would you say to a friend who's gone through this, and can you say that to yourself? Writing a letter to yourself from a place of compassion. Empty chair with criticizer, criticized, and compassionate observer. Changing critical self-talk, self-compassion journaling, and working through emotions in the body. The third paradigm after the behavioral and the cognitive is physiological. The goal here is mindful observation of physiological activation, and this is useful for clients who are disturbed by the physiological activation. They feel very overwhelmed by it. They have difficulty sitting with those, physical sensations, those feelings as they emerge. We would help a person through this by first helping them just become aware of their bodily state. Often they become numb to feelings within the body. And so we might ask them just to notice things like muscle tension when they're not in a distressed state, right? To notice like how they feel within their body. Can they notice their feet touching the floor? Those types of basic things, okay? Eventually, we would have them also notice the experiences that happen during activation, right? And just be noticing them and trying to accept them as part of their experience, okay? Not from a place of liking. Acceptance is different than embracing, right? Just accepting that they're there and also understanding why they're there, right? That it's the body's attempt to protect us, and while it may be unpleasant, that it kind of makes sense the body would do this, okay? Rather than rejecting or trying to stop it, just kind of from a place of, okay, let's acknowledge it. It's here. It's my body's way of trying to protect me, and it's not something I need to worry about. The theoretical approaches that follow this format are the mind-side approach of Dan Siegel, or interpersonal neurobiology, Bessel van der Kolk's work, Levine's somatic experiencing, and a team that I have been a part of, neuroscience-informed CBT. The anticipated outcome of all these things, behavioral, cognitive, physiological, is for a client to embrace the understanding that their body is going to respond a certain way in response to this event, and they don't need to feel bad about themselves. What happened to me in the past was horrible, and my body remembers to protect me and make sure this doesn't happen to me again. My body is doing what it's supposed to be doing. Okay, in summary, traumatic stress has a strong neurophysiological foundation. Survival is a primary motivator for all living creatures. We overcorrect in response to a survival threat. The body's overcorrection cannot be easily changed through self-talk, okay? Often we have to do exposure-based work or self-compassion or acceptance of experience. And the reason for that is think about what we've learned about the prefrontal cortex getting offline, if you will, right? During the secretion of adrenaline, right? That you're not able to think yourself through these experiences. You should select treatment approaches based on presentation And you should know that treatment can be extended because the client may not be ready, right? The client has to be ready to work through these things. They have to be ready to get in the car, right? If they've experienced that motor vehicle accident, or be ready to talk about that roadside bomb incident, right? If they have these negative appraisals. When they're ready, then we can make progress, but it takes a while for a client to get comfortable and ready. And that concludes this video lecture on stress and trauma.